of the physiotherapy lectures, I'm going to do some accessory movements on the wrist and hand complex. So the accessory movements we would focus on, a little bit like we did in the lower limb, if you've seen the lower limb clips, are grade 3 oscillatory movements. So that tends to be what's done clinically. Large range oscillatory movement into resistance towards the end of range. We'll also do some grade 4s, just touch on those, small range oscillatory end of movement. First one we're going to do is the radiocarpal joint. This is done a lot where you've got stiffness into maybe wrist extension and flexion. So what we would do is fix the distal radius, mobilise the proximal carpal row. Okay? Just going to fix the distal radius, proximal carpal row, and then we're going to mobilise. So this would be a PA movement, particularly good for wrist extension. Big grade 3, big oscillatory movement well into resistance towards the well into the end of range. Probably do that for about a minute and then retest extension. So I'm fixing distal radius, mobilising proximal carpal row. To do a grade 4, what we would do is probably go to the end of range, come back a tiny bit, do a small range mobilisation at that end of range. So the grade 3 is a large range, grade 4 is small. Another joint that we do a lot of accessory movements on is the first carpal metacarpal joint. So that's that saddle joint between the base of the first metacarpal and the trapezium. So we would find the trapezium, the base of the first metacarpal, fix the trapezium, and we could mobilise in it from the back of the metacarpal into a PA, or we could do an AP where we bring it back. But I think in reality you'll probably do both together. It's not pure textbook, but then clinical practice isn't pure textbook. Probably just mobilise in both directions before, and you should feel lots of movement. You feel lots of movement there? Yeah, I feel lots of clicking and clunking. We also might want to do it, maybe someone's had maybe a fractured metacarpal, soft tissue injury to the hand, they've got some stiffness in those metacarpal phalangeal joints. So we would fix the metacarpal head and then mobilise the proximal phalanx, like so. AP coming back, get lots more movement in doing an AP. And you can also do a PA. And you can also do the same down at the intraphalangeal joint. You don't get much accessory movement from them because they're a hinge joint, whereas the MCPs are more of an ellipsoid joint. Okay, we're just going to move up to the elbow joint complex. What's commonly done in the elbow is accessory mobilisations of the radial head. Can you see the elbow there, Toby? So we're going to find the radial head, which is in this kind of little dimple or space here, and we can confirm it's the radial head. It should move if we pronate and supinate. So we're going to put our thumbs on the radial head, and we can do a nice PA movement like that. Do a nice PA movement, big oscillatory grade 3, or we could go to the end, come off a little bit and do a smaller grade 4. And that's used for a lot of those stiffer elbows. What we can also do when we have Jake line here is come up to the shoulder joint. So what we commonly done in the shoulder joint is a nice AP mobilisation. You can do this in several ways, but I think a nice way to do it is to fix the scapula behind, thenar eminence, proximal humerus, do a nice AP movement. It's a nice anterior stretch. big grade 3 movement, big oscillatory movement, large range. Do that for a minute or so, then maybe retest maybe flexion, lateral rotation. You can also do that AP movement in different parts of the range. So let's say we could do it maybe in 90 degrees abduction, proximal humerus, and mobilize. So this is quite a young shoulder, very mobile. It's got nice lots of clicking there. Or it may be that the problem is more that last third. So we could also do it up in that position, just taking care that you're not in the axilla on the brachial plexus. Another commonly used accessory movement in the shoulder joint is a longitudinal corridor, an inferior movement. So we could do that. So you might need to move around to there to see me. So I'm going to get just come off the acromion process, and we would do a downward movement. Big, large, grade 3. But we might want to do that at 90 degrees abduction or somewhere else in the range, which we can do. So we would do it like so. Or we might want to do it towards the end of range. So we just come in like this and do it like that. But I think it's just remembering as you go further into the range, you'll tighten up some of those articular structures, so you'll tend to get less movement. And sometimes when you're at the very end of range, you might end up doing more of a grade 4 movement. We could also do some accessory movements in the acromioclavicular joint. So that might be a patient who's maybe been playing rugby, had a strain to that acromioclavicular joint. It's now stiffened up, it's not moving, or someone who's maybe had a clavicular fracture. So we could get on lateral end of the clavicle, which we can feel, so we can feel lateral end of the clavicle, acromion, we can feel the joint. So we're going to mobilise in an AP direction on the lateral end of the clavicle. So thumbs, lateral end of the clavicle, and we can mobilise in an AP direction. Could also do a caudad inferior movement on that, and if we got him lying on his front, we could do a PA movement. But usually the AP is probably sufficient to get that joint moving. But we could also, because acromioclavicular problems kind of tend to be in the last 1/3 of movement, we can also mobilise that up in this position here. Okay, so could we maybe now just turn that off?